eyes. Okay, having said that, let's look at what the Corvus and the biomechanical corrected IOP looks like, measured with the Corvus ST before and after laser vision correction. These are my co-authors. I have been fortunate enough to publish this paper in the JCRS just last month. We showed that the Corvus ST was capable of discriminating from post PRK and post femto LASIK eyes, which we all know that femto LASIK is probably weaker after surgery, and no one has able to quantify the means, but Corvus ST is sensitive enough in this regard to discriminate between post LASIK and post PRK eyes. So we retrospectively enrolled around 65 eyes from each group after femto LASIK and after transepithelial PRK, before and 6 months after surgery. Now, I think the most important thing here is that although we didn't do a direct vis-a-vis comparison with Goldman's applanation, we did do a vis-a-vis comparison with a non-contact tonometer, and showed that although the CCT, of course, has been reduced after surgery, and the NCT, the non-contact tonometer, shows a consistent decrease after surgery, the biomechanically corrected IOP measured with the Corvus remains stable. Now, this has tremendous implications for glaucoma patients, for steroid-induced ocular hypertension screening, and as of this minute, because the Corvus ST has only been licensed to be sold in the United States as a tonometer, this fact alone in the United States is something that we all need to take into regard when evaluating ocular hypertension after refractive surgery, when the cornea actually gets thinner. And evaluating all the DCR parameters, we saw earlier today from Vishal's talk and Tammy's talk that the deformation amplitude at 2 millimeters was one of the important variables in discriminating from keratoconic to normal eyes. And as was such, it was exactly so after refractive surgery. We saw that the SPA1 and ART-H show differences. The DA2 and the integrated radius. Now, if we look at the percentages here after femto LASIK and PRK, we can see that PRK is weakening the cornea by about 19 to 23%, around 20%. But femto LASIK is weakening the cornea to another extra 10 percentage points, around 30%. And this kind of damage that we are actually performing on the cornea has never been before quantified. DA ratios 1 and 2 millimeters, and integrated radius has been explained by my previous speakers. If we look at this graphically, we can see that when we look at the integrated radius and DA2, that femto LASIK and PRK show almost parallel regression lines. They don't meet, which means that these parameters are very distinctly different for femto LASIK and for PRK. And for integrated radius, we can see that over a whole diopter range of 150 microns of tissue and over a diopter range of 8 diopters, that this change is consistently seen with the Corvus ST. ANCOVA and covariates also validify these findings. And the biomechanically corrected IOP, we see that they are almost stable throughout 150 microns of pachymetric change and 8 diopters of spherical equivalent change. So, post-op changes in DA2 and integrated radius after PRK are significantly smaller than those after femto LASIK. Surface ablation has the smallest additional effect on corneal biomechanics. So we demonstrated the reliability of the biomechanically corrected IOP or BIOP estimates obtained by the Corvus through these results, and This result indicated that the reduced effective changes in corneal thickness and material behavior on BIOP measurements compared to uncorrected intraocular pressure estimates. Another follow-up study showed changes before and after corneal collagen crosslinking. We compared extra procedures from trans-PRK alone to trans-PRK extra and tried to quantify changes, if any, if we could quantify any changes with the Corvis ST. And we published this earlier, I think it was in June last year in JCRS. We enrolled just over 40 eyes from each group and demographically matched both groups. For both groups, TPLK and PLK extra, the final resulting vision and refractive error were very comparable with no significant difference for both groups. However, for DCR parameters, we can also see that it is the DA 2 millimeters and the integrated radius rather than the ART-H or the SPA1 that show significant differences before and after corneal collagen crosslinking. And the ANCOVA regression lines also, as seen before, comparing LASIK with PLK, showed distinct parallel lines between cross-linked and uncross-linked corneas. SPA1, there were significant differences in pre- and post-op SPA1 between the two groups. As Tommy explained very well in the previous lecture, SPA1 is an inward pressure of the cornea divided by its actual full load, the loading and unloading. So in conclusion, we suggest that PLK combined it with a prophylactic cross-linking procedure, such as the PLK extra, intervention appears to have a role in causing a smaller reduction in stiffness of the corneal tissue relative to the uncross-linked PLK, which means if we're cross-linking at the same time as we're doing PLK, we are causing less amount of biomechanical disturbances on the cornea. Thank you very much. Okay.